So it's my great pleasure to introduce one of our patients who is a talented young man who felt comfortable coming up and doing the public speaking to share with you a little bit about his experience as a Kawasaki disease patient. So Luis Bariwan, it's my pleasure to introduce to you, and he'll be followed by Professor Elliot McVeigh, John Gordon, and Sam Cohn. So, Luis, it's all yours.
High fever, rashes all over the body, dengue fever misdiagnosis. Then, the strawberry tongue, coronary artery aneurysm, Kawasaki disease. This is me. When I was 2, my parents immediately rushed me to the hospital with high fever and rashes. Initially, they treated me with dengue fever, being that dengue fever was common in the Philippines. But after, the strawberry tongue appeared. The doctors immediately knew that it was Kawasaki disease. They administered IVIG, or the intravenous gamma globulin treatment, a medicine deemed to be a powerful relief to the symptoms of the disease. Fortunately, my parents were able to afford the medication during that critical moment. As a sad truth during that time is, a lot of people in the Philippines were not able to afford the medicine. The treatment was like a sword that slashed through the grappling tentacles of Kawasaki disease, and I was freed. But the damage was done. In fact, I acquired 2 coronary artery aneurysms in both my right and left coronary artery, which was first seen through the echocardiogram. It was by all means considered to be a giant aneurysm, about 8 millimeters in the right and 5.5 millimeters in the left at maximum, as measured constantly by the many echocardiograms and examinations that I had, which peered through the inner structure of my heart. After recovering, my parents said I was thin and I seemed sickly, which is a contrast to what I was before. In the next few years, my doctors monitored my condition continuously. Through echocardiograms, regular blood works, they monitored me cautiously. As an added measure, they even did not let me participate in physical activity since I got so tired easily and my heart rate shot up with minimal exertion. A few feet of running and I was huffing and puffing. This is me. I remember how I felt when all of my peers in elementary school were having fun running, playing, while I sat in a bench. Instead of running, jumping, and playing in my PE classes, I was taking quizzes on the history of basketball, volleyball, soccer, and I was making countless diagrams of basketball courts and football fields as a project for my grade. What a great way to love physical education, am I right? But my story did not end there. When we moved here to the United States from the Philippines about 5 years ago, I came to Radio Children's here in San Diego. This shows my visit to Radio Children's. I recall it was in April 2013. In the following years, Dr. Burns and the Kawasaki research team monitored me. But before I go on, I want to say thank you. I applaud you. I am here because of you. Thank you for taking care of me and helping me regain a normal life in my teenage years where the normal was crazy. They encouraged me to participate in physical activity, with caution in mind, of course, as I was still taking blood thinners. So as a result, I could not participate in contact sports, so no football for this 5'6" young teen. However, I slowly gained an ability to increase my physical activity in the following years. I began to take physical education classes in school, which I have not done until then. Once I got into high school, I was even able to handle a rigorous physical education program, which was by no means easy even to other students, where the average fitness day makes kids vomit. However, running 5Ks and 10Ks regularly became doable even for me. My teachers would actually be very surprised at what I was able to do despite my condition. It eventually became apparent that I was running, jumping, and playing alongside my peers, these things I would not think possible until then. Today, I've become used to exercising on my own initiative, as back then, I didn't particularly like exercising since I was not used to it. But aside from physical activities, another aspect of my life that changed dramatically is food. With the new medical developments that is possible through patient participation in research studies, I've had a relatively normal diet. A few years ago, before taking my current medication, I was taking Coumadin. I didn't really like taking it since it limited my diet. I was not allowed to eat foods with high levels of vitamin K. Imagine this, being told that you're not allowed to eat leafy greens, some vegetables, and many more, things that were good for you. We'll talk about slicing and dicing a portion of the food triangle. But now, with my current medication, I'm able to choose what I want to eat. Plus, I don't have to get my blood drawn nearly every month, which I've gotten so used to over the years and has become my normal, like drinking water. So I believe it is our responsibility as patients and families to participate in these studies to aid medical progress in this area, which allows life to be better for patients like your child and me. Taking all of this into account, my intent on sharing my story is to show and demonstrate something to all of you, something very important. That anyone who has the same medical condition as I do can live a healthy and normal life. With the medical developments today and in the future, your child can live a normal and happy lifestyle, just as I did and will today and in the future. And this picture actually shows my final visit in the Katy Clinic about a month ago. I have graduated. Dr. Burns showed my family images of a comprehensive CT angiogram that was performed a few months ago. You can see the 3D model of my heart. You can see here are the two aneurysms. This is the right aneurysm, and this is the left aneurysm. Here's it from a different view. You can see that the 3D model of my heart and the aneurysm is still there and has remained fairly constant, and it's predicted to remain stable in size in the coming years. But even with this situation, I have to say that I live a healthy and happy lifestyle, much like any other teenager. I am able to have fun and do activities that I did not think I would be able to do a few years ago, thanks to the intensive care Dr. Burns and the Katy team, my parents and family, that they have provided over these past few years. Truth to be told, my main preoccupations are not particularly focused on my condition, but on things that I'm passionate about, such as giving a TEDx talk, starting a piano club, or even last summer, astrophysics research identifying black holes at Michigan State University. But also in things that teenagers today are busy with, such as the dreaded college apps, schoolwork, and lastly, building friendships and relationships. So I stand here as a thriver, as a person who is thriving, thanks to all of you. Thank you.
Luis, that was incredible, and I'm sure that there are many parents who would love to talk to you in our next opportunity, our next break. It's my pleasure to introduce now Professor Elliot McVeigh, who wears many hats as a bioengineer in the Department of Radiology, and whose research I think is going to potentially have a great impact on the future of our Kawasaki disease patients. Elliot, thank you.
Thanks, Jane. And Luis, that was a fantastic account and a great talk. Congratulations. And best of luck in astrophysics and all of your endeavors there. What I'm going to show today is what the new generation of CT scanners can accomplish in terms of performing non-invasive diagnosis of diseases of the heart. And these scanners are quite spectacular. Now, there's been a significant commitment by vendors to improve these devices and also lower the amount of radiation that is used to make pictures. This spinning heart here shows tremendous detail in the coronary anatomy, which is something that we're all concerned with basically throughout our lives, and most of us are not concerned until we reach my age, about 50, when you want to see if you have some disease in your artery. And this data, or this image, is obtained now in a single heartbeat on a modern CT scanner with a very limited amount of radiation. So about approximately 2 millisieverts, which is about 60% of the radiation that you receive just walking around being alive. So every year you receive about 3 millisieverts of radiation from radon and cosmic rays and things like that. And so now the dose of these devices has dropped down below this background radiation. The interesting thing also is that this is an image of a heart that is in a stationary condition. And so this is at end diastole when the heart is full of blood and it's not pumping. And so you make an image of these detailed structures. The reason you can make an image so quickly is that General Electric and Canon and Siemens and Philips and large companies like that build devices like this one that I'm showing here. This CT scanner spins at an extraordinary rate. The gantry that takes the pictures, the individual pictures of the patient from different angles, is spinning around the patient about 4 times a second, some of them even 5 times a second. And so because it's spinning so quickly, you can get all of the views you need to take a picture within about 150 milliseconds, or about 1/6 of a second. So it's inside one heartbeat, you get a snapshot, and you can get that very clear picture of the heart, and you only expose the patient to radiation for a very short period of time. It's an extraordinary thing that this is the camera, essentially. It's like your phone has a little array, pixel array camera behind the lens. This is a pixel array, but it's a much bigger one. And but it has 256 pixels this way and about 1,000 this way. And the X-ray source is here at the top. And the X-rays come through here and take individual pictures from different angles. And all of those pictures are used to create that three-dimensional image. All of this mechanical structure is rotating very quickly. And in fact, the forces here, when it's rotating, are about 80 Gs. And a human, when you're in an airplane, if you're a fighter pilot, like these pilots that are flying around now in the air show, if they pull as hard as they can and turn as hard as they can, before they pass out, that's about 6 Gs. And this is at 80 Gs. And so there's remarkable forces that these machines have to put up with. But the companies have made the commitment, and they build these, and they make these fantastic pictures of the heart. This is the scanner that we installed at UCSD about 18 months, 2 years ago. And it's the same one that I just showed you. It has a very wide detector here, and this is this whole device here spins around. And the covers are put on the scanner so you don't see all the mechanics of the spinning. It's quite scary when it's off and it's spinning. You actually don't want to see it. Granted, if something came off, it would fly out. It would fly away from the patient, but nothing ever comes off. But what you can do is, if you continue to obtain data for the whole heartbeat, say for 1 full second, instead of just 150 milliseconds or 1/6 of a second, let's obtain data for a whole second, you can get individual pictures of a beating heart. And so you can look at the function of the heart in the same way that you look at the function with echo, but this is done at the same time that you're doing the coronary angiogram with CT. And you get extraordinary contrast between the blood pool in the left ventricle and the myocardium, which is the muscle, and this is the right ventricle, and then the muscle around the right ventricle. This is the, the diaphragm here, and the chest wall is up here. So we're looking at particular views of the left ventricle with this reconstruction. So we basically take the full 3D data and take a cut through that data. Equally impressive is when you look at that 3D data all at once. So what we're looking at here is the contrast agent that is in the blood pool in a beating heart. And we're looking at that at about 10 times through the heart cycle. And it gives you this fantastic movie of the function of the left ventricle. And so this is essentially the blood that is in the left ventricle, and it's shrinking down as the heart is ejecting 50% of the blood out of the ventricle. This is the aorta here, and then you can see the coronary arteries coming from the aorta. That's the spine, the descending aorta, and this is the left atrium. And so we're able to get this really nice three-dimensional, in fact, it's a four-dimensional data set. It has 3 spatial dimensions and time. Classically, the way you evaluate somebody's cardiac function, their left ventricular function, is you look at how much blood gets ejected on each beat. If you plot on this axis the volume of blood in the ventricle, and on this axis time, you can see as the heart ejects the blood, the volume goes down, then the blood goes back into the ventricle, it rests for mid-end diastasis, the atrium contracts and fills it completely. And so you basically compute an ejection fraction, what percentage of blood is ejected. That gives you a global functional metric, but it's not very specific. This is an angioscopic view of a human left ventricle that has been filled with an oxygenated fluid that's clear, and you can see the remarkable structure that's on the inside of the human left ventricle. These are called trabeculae, and they're very, very fine little pockets of muscle. And these movies were made by Medtronic. They were looking at what it looks like when they put a pacing catheter in there. But on CT, because computed tomography is so good now, we can actually visualize these structures on the images. On MR, you can't do it. On echo, you can't do it. You just don't have the resolution. But in CT, when you look at the left ventricle or the blood pool, you see all of these structures, And when you play the movie, you can actually see those structures change their shape. So what we do is we look at those structures and we track them in time and in space. And at a specific position on the left ventricle, we will compute how much muscle contraction is occurring by looking at how this shape is changing over time. And if we plot feature detection on the surface of the left ventricle, the yellow are the valleys and the blue are the hills on those features. Those features tend to move and we can track them, right? So they're like fiducial markers on the surface of the ventricle such that we can calculate how much contraction is occurring at each point on the left ventricle. So mathematically, we have a heart at end diastole. When it's full of blood, it ejects blood and goes to end systole. We track all of the points on that surface over that trajectory, and then we plot out the function on the surface of that heart. In this case, blue means the muscle is contracting and it's coming together, and that's normal from end diastole to the end of contraction. And then this section here is abnormal. You see it still remained yellow, and that means it expanded, so it didn't contract. It was left behind. And you can see that abnormality quite clearly. If you look at 25 normal left ventricles, and in each part of the heart, so this is the base of the heart, the middle part of the heart, and the apex in these rows, each one of these little graphs gives the function at that position in the heart. Here we have something that's in the mid-septum. There's contraction, and then filling, and then rest. And then the dark black curve is the mean over 25 people, and you can see that's quite reproducible from person to person, and we can measure it very precisely. When someone has something wrong, and you can see right there, I'm going to pull that back here. So you can see on the surface of this heart, this is a little noisy because this was done with very few x-rays, but that position right here is really not changing its shape over the heartbeat. It's kind of left behind, doesn't crush down, and that tells you that that little part of the left ventricle is abnormal. So you can go in and locally see this abnormality. In this patient, and this is a little blurry because this was done with remarkably few x-rays, this part of the ventricle actually is not contracting well. And you can plot that function with those graphs, and you say, this is what, at this position of the ventricle, over time, the contraction should look like this. It should go down, the tissue should shrink as it's being contracted. In this patient, actually, it's going the wrong way. It's actually expanding and then coming down at that location. Down here, we can see this patient, their cardiac function is okay at that location. So you get a point-by-point estimate of what the function looks like in the heart. Here's what a normal heart looks like, and this is actually this was about 1.5 millisieverts of radiation, a very low radiation study. And these patients are undergoing anthracycline therapy, and we're looking to see if the therapy changes their cardiac function over the course of the drug when they're getting the therapy. And so this was the baseline study for this patient. And then we compared, remember those graphs that look normal function it goes down here and then back up. So the red curve in this patient was what the cardiac function was at that position in the heart pre-anthracycline therapy, and the blue curve is post-anthracycline therapy. And you can see it reaches the same amount of function. So in fact, this heart does not seem to have suffered at all under this regimen of drug. Okay? The heart rate got higher, things happen more quickly. So here the heart rate was 55, here it was 75, but the actual function seems to have remained intact. And so it's a very precise way of measuring that regional function. And so just to summarize, with these new CT scanners, these ones that have high, fast spinning and wide detectors, we can get this imaging data in very low dose and get it in a very short amount of time. And that allows us to get both coronary anatomy and angiography to look at the arteries themselves, look at very fine structures inside the artery, like this tiny piece of calcium here, and then also get this left ventricular and even atrial and right ventricular function of the heart if we take the data for the whole heartbeat. Okay? So thank you very much for your attention.
Elliot, thank you so much. And we're going to hear from one of our research associates about a study that we'll be doing with Professor McVeigh with our Kawasaki disease patients, because we've learned over time that the heart muscle can be affected in patients with giant aneurysms, and we want to be able to image that and know about that and follow that over time in our patients. It's my pleasure now to introduce Dr. John Gordon, who is a member of our adult Kawasaki disease team. So those of you who have come to our symposium in the past know that we are really fortunate to have 3 adult cardiologists who are part of our team here at UCSD and here in San Diego. So Dr. Gordon is the interventional cardiologist at the San Diego Cardiac Center. Dr. Lori Daniels is the head of the Symposium cardiovascular ICU here at UCSD, and Dr. Andy Kahn works very closely with Professor McVeigh and is a cardiovascular imager. So we are really unique and fortunate here in San Diego to have one of the few adult Kawasaki disease teams, perhaps unique in the world. I'm not sure, I haven't really heard about other dedicated adult KD teams. But we're delighted that we have a way to pass on our patients as they grow up who have giant aneurysms or important cardiovascular changes who need follow-up from an informed group of adult cardiologists. And so we're very pleased to have Dr. Gordon here with us today.
Thank you very much, Jane. Good morning. As was said, I'm an adult cardiologist, so I'm really unique in this in this gathering because I'm the only one here who really takes care of adults. So all of your children presumably are going to grow up, and what we are concerned about is the possibility that they could have a heart attack or that aneurysms will lead to problems. And so what do we do about that? Jane asked me to speak for about 10 minutes on how we keep our Kawasaki patients safe, so that's what I'm going to try and do. This is a photograph of Dr. Kawasaki, the young Dr. Kawasaki, who did a remarkable thing. He saw something that others did not see, which was a new disease. But what he couldn't see was that some of these patients were going to develop aneurysms and were going to have problems down the road. What I'm going to show you next is one of my first patients who presented with a heart attack due to large aneurysms that weren't recognized. And this is, in Kawasaki disease, one of the big problems. It's not seen, it's not recognized, it's not treated. And so I'm going to share with you how we do try and recognize things and ultimately how we treat them. So 32-year-old young man from Laos who, at the age of 2 had a disease where they thought he was going to die, didn't know what it was. And he presented 30 years later with chest pain. He didn't really have any traditional risk factors for coronary artery disease. And this is what we saw on his initial angiogram. And what you can't see very well is his right coronary artery, which is totally filled with blood clot, and it's a giant aneurysm. And so what do we do? This is a big artery filled with blood clot. And what we do is we advance a wire through this blood clot, put a balloon in there, and what you can see is we've got a little bit of flow going through the artery. And now you can see the distal part of his artery down here. And he was much better at that point because his heart was being perfused. We put him on some medicines, and 2 months later, this is what it's supposed to look like. And what you see proximally, or in the early part of this artery, is a markedly dilated giant aneurysm. And if it's not treated with anticoagulants, blood will sit there, blood will clot. And that's what happened at age 32 for him. Unfortunately, he had a good result. We got his artery opened up quickly enough, so his heart's working well. And I suppose if we sent him to Dr. McVeigh, we could see that he does have some fibrosis on the inferior part of his heart. So how do we screen for patients? There are a number of patients who come through Dr. Burns, Dr. Tremollay's clinic. They have a history of Kawasaki disease. Echoes actually probably look okay. But do they have aneurysms, or are they at risk for problems? Or some children were told they were fine. We now have a very simple test that simply looks for calcium in the coronary arteries. We don't even do an angiogram necessarily, but we do what's called a CT coronary calcium score. And this test will tell us, as I'll show you some data in a minute, if there's an aneurysm. And this is a CT calcium score performed on the 35-year-old uncle of one of Jane's patients, who said, I had Kawasaki disease when I was a child, but I think they told me I was fine. Am I? Well, it turned out he had a quite high calcium score. And so we then did a proper coronary CT. And you can see where this arrow is pointing that he has calcium around a fairly large aneurysm, about 7 millimeters. So he was treated with warfarin at that time. And we would use different medications now, but warfarin was the standard of care then, and maybe still is. And he's done well. This is an aneurysm that we may have discovered when he had a heart attack, but I think we've avoided that with a simple $100 test. And these are the data from the San Diego Collaborative Adult Study that helped us to recognize this patient. So this is the result of our local research, which basically shows that after 10 years, so if you look here on this axis, 0, 10, 20 years, after 10 years, and these blue squares are our patients with aneurysms, all have, with this exception, calcium that is a signal that there's an aneurysm. So if someone doesn't know that they have a problem, we can do a $100 test, find a coronary aneurysm, and initiate appropriate therapy that will prevent a heart attack. And I just want to emphasize, this is one of the key findings of our local research, which is one of the reasons that you want to participate. So, how do we follow up our adults who had KD? Well, if there were no abnormalities, the calcium score is fine, everything is normal, the kid is normal, or the young adult is normal, no need to worry, sleep well, and can be discharged from care. What about children who had or have transiently dilated arteries in the acute phase? We do the same kind of follow-up with a CT calcium score, and a small percentage of them are going to have a problem, which is why this test, I think, is important. But if it's normal, 20 years down the road, then we feel that these patients are no longer patients. They're fine, they're going to do well, sleep well. Aneurysms, if you have aneurysms in childhood, then I think it is something that we need to pay attention to, because you can get a stenosis, you can get thrombosis. And once again, we'll follow with a calcium score. We do a stress test for these patients, a stress echo, and we treat them with aspirin if the aneurysms are small. And this just illustrates what a stress test looks like. This is somebody walking on a treadmill. You're all familiar with these things. But it turns out to be a very good test for determining whether or not the arteries have narrowed or have a stenosis. The special case in the patients that we're most concerned about are those who have giant aneurysms. And that has traditionally been defined as greater than 8 millimeters. And these patients need lifelong follow-up, which would include stress echoes, electrocardiograms, and so forth. And these patients need to be anticoagulated with warfarin or with the what are called DOACs or NOACs medicines like Eliquis that you've heard about on television. And when do we do things as dramatic as bypass surgery? This is one of our young adults who was followed up in Northern California with serial CTs, which showed progression of stenosis before and after the aneurysm that you can see here. You can see how it's hazy before the aneurysm and after. And what we did a stress test, and we did what's called fractional flow reserve, which is a special kind of test that helps us predict who benefits from an intervention. And this is an abnormal FFR, and she underwent a single vessel bypass, internal mammary artery to her artery, which should be a durable, should give her a durable, safe outcome. And I'm just going to show you one other just interesting contrasting case. So we had another young adult who had asymptomatic but very severe coronary disease. This is where the left anterior descending artery is actually occluded. You see just a little trace of it here. This is the circumflex, so this is the left coronary. But his left anterior is occluded, and you can see that this left anterior descending artery is actually getting perfused quite well by collaterals. His right coronary supplying bypasses to his left coronary. He's fine. He doesn't need a bypass. He actually swam competitively in high school. All right, so we have good tools to prevent complications. We've got a very simple, inexpensive tool for picking up this coronary calcium that helps us to know who is at risk. We have new medical therapies. We're no longer, I think, using warfarin, Coumadin, despite guidelines, because we have safer, better medicines. And ultimately, this all needs to be studied. And proper clinically controlled trials will be performed. That's down the road in the near future. We can use stents, we can do bypass if necessary. Jane asked me to show you this slide just to encourage everyone to participate in the clinical research that we are doing here in San Diego. To join, the email address is below. So the future is bright, particularly if we continue to do the research that is being performed here in San Diego. Thanks for your attention.
Thank you, Dr. Gordon. So we're going to take questions at the end. Sam Kung, who is a medical student here at UCSD and is taking a year to learn more about doing research, is going to tell you about a new research project that combines what you've heard from Dr. Gordon along with Professor McVeigh. Sam, welcome.
All right. Hi, everyone. Thank you for that introduction, Dr. Burns. Again, my name is Sam. I'm a medical student here at UCSD. And today I'm just going to discuss more about some new studies that we have planned for KD patients. In particular, we want to learn more about KD's long-term effects on the heart. So I'm going to talk to you a bit about this upcoming study here. Basically, we know by now that there is not only evidence of some remodeling or some effect that KD has on coronary arteries, but there's also some evidence to suggest that KD also affects the heart muscle itself. We also know from Dr. McVeigh's excellent presentation on just the new cardiac CT imaging technique that his lab has recently developed. So the intention is to use squeeze up there to leverage this technology in order to see what we can find in KD patients. So the objectives of this study are to see if in KD patients with giant aneurysms, we want to see if there are higher levels of inflammatory protein circulating in the heart. In addition to that, we also want to see if squeeze added onto these cardiac CT scans will give us any new information about heart function itself. What that means is that the study itself is quite simple for the patients, actually. It involves two main things. At each clinic visit where a blood draw is required, essentially we'll draw blood, and from that blood we'll be able to identify any potential proteins and other markers for inflammation and scarring. And in addition to that, for each scheduled CT scan in these patients, we will also add squeeze analysis to it to help us visualize the heart. So the question is, who can participate? We are primarily looking for KD patients. We're actually only looking for KD patients at this point who have giant coronary aneurysms. For the blood draws themselves, we are looking for patients who are 3 months old and older. For squeeze, the cardiac CT imaging, we are looking for patients who are ages 13 and older. And those who can't participate include patients who have had a previous coronary surgery bypass, or coronary artery bypass, or if they've had an implanted defibrillator or other thoracic surgery with metal or other sutures. And of course, if you are pregnant at the time of what would have been your scheduled CT, obviously, this would also be a limiting factor in your ability to participate. So essentially, we are hoping to start enrolling patients sometime around December, January, depending on other factors at this point. But if you have any questions, we will be here to answer them. Thank you for your attention.
Thank you, Sam. So that concludes the presentations for this morning, and now we're going to have questions again. Some of these are left over from earlier this morning that we triaged to be the more appropriate group of presenters talking about them here. So this is one about anticoagulants. And so please write down all of your questions and pass them down so we can get them down here for people to address.
So one question is, are there better anticoagulants than others? Are there studies for other anticoagulants? And the answer is none of the anticoagulants have been very well studied. But what we have learned in adult cardiology, taking care of patients with atrial fibrillation, is that there is a much safer approach to preventing blood clotting and stroke than warfarin, which is traditionally the drug that we've used. So we are now, in general, switching over to these new novel anticoagulants. You've heard about them on television. Eliquis is an example. And this will be studied. There's a study that has been organized and funded and will be getting started. So we're going to answer the question scientifically, and there's a better way. Okay. So when do we recommend children with Kawasaki disease to start looking for calcium CT? So what we learned from in our adult Kawasaki study was that if there are aneurysms, we begin to get a signal 10 years after that presentation. And typically what we will do is we will look in our young adults. So, and there isn't a magic number, but certainly 10 years down the road, young adult who does not know if he or she has a problem. And as long as it's 10 years hence, it's appropriate at that time to do a coronary calcium score, which, if it's 0, is a very good prognostic sign. Okay. So is the calcium test something that is tested on a normal blood panel at checkups by a primary care physician, or is it something different? It's something quite different. It's done in a radiology department. It's actually a CT scan, and we've seen Dr. McVeigh's really fancy one. It doesn't actually have to be quite that fancy, but it's a CT scan. And it's something that insurance typically doesn't pay for. It costs about $100, but it's done in every hospital, and there's some outpatient CT scans. If my child's echo is normal, what is the likelihood of a heart attack as an adult or aneurysm? And so if at presentation the echo is normal, if at follow-up the echoes are normal, the chances are that child is normal. And if there is concern, and we will typically, so if I met this patient in my office and he's 25 years old or she's 25, I would just say, let's do a $100 test and prove that everything is fine. But generally, if everything is normal, the child is normal, everything's going to be fine.
So a question we got is SQUEEZE an acronym for this type of imagery imaging that I had mentioned? So SQUEEZE actually stands for Stretch Quantifier for Endocardial Engraved Zones, which again, it's a mouthful to say, but essentially it's the same type of fancy CT imaging that Dr. McVeigh was previously talking about. That's just what SQUEEZE is.
Here's a question. What other effects does KD have as the child grows? So what happens when he's a teenager or a young adult? Well, KD typically affects the heart and occasionally will affect other blood vessels, but really nothing else. And so if everything was normal at the beginning, as I said a minute ago, everything is fine, prognosis, great. If there are aneurysms, if there are vascular abnormalities, those are things that need to be followed. But I wouldn't expect that the child would have any particular disease otherwise. He or she is otherwise a normal person. Diseases do happen, but they're not related to the Kawasaki disease.
There are a couple of genetic type questions, so I'll field those. One is from someone whose daughter had Kawasaki disease and bypass surgery and is now pregnant. Should the baby have any testing? So unfortunately, we do not yet have a specific genetic test for Kawasaki disease. However, the signs and symptoms of Kawasaki disease are pretty clear, and having been through Kawasaki disease before as a parent, now as a grandparent, you will certainly recognize it in the child. We don't even have the ability to put a number on the risk. In Japan, they've looked at it the other way around, where they say if you have Kawasaki disease, you have a twofold increased likelihood that your parent also had Kawasaki disease. But what we really want to know is the other way around. If you're a mom and you're pregnant and you had Kawasaki disease, what's the chance that your child will have Kawasaki disease? It's not 100% and it's not 0, and it's somewhere in between. And we hope that you are enrolled or will enroll in our adult KD study. And as we gather data about pregnancy in our former KD patients, then we'll have a better grasp of that information. Another question from someone was, neither I nor my husband had any family history of KD. How did my child end up with KD? And that's a great question, because I think we often conceive of genetic conditions as being a single mutation, things like cystic fibrosis or sickle cell disease, where there's a person who's a carrier, and then if the child inherits the mutation or 2 doses of the mutation, they will definitely get the disease. Kawasaki disease genetics operates in a different way. And that is that there are many different genes in various pathways that are present in a form that is not necessarily a mutation, but just one of the variants that are present in the population. And if they have multiple variants that all line up a certain way, so a very complex pattern, that creates the susceptibility for Kawasaki disease. Now, we're still looking very carefully for more rare, potentially greater effect variants that if you carry it, you're much more likely to get Kawasaki disease. But so far, the variants that we found are things that are present in the population. So both mom has some of those variants and dad has some of those variants, and they got together in the sperm and the egg in that particular child. So it's a complex pattern, and that's why when you come into our clinic and you participate in our genetic study, we get DNA samples from the biologic father, the biologic mother, and the child, so we can begin to understand how those patterns are being transmitted.
There's a vaccine question.
Okay, vaccine question. Son had the MenB vaccine 16 weeks before KD. Is KD a side effect? Let me emphatically say that there is absolutely no documented relationship between any vaccine and Kawasaki disease. And I have served on a couple of panels from the vaccine companies where we actually reviewed cases of children who developed Kawasaki disease after being vaccinated with whatever vaccine was being tested. And, you know, this is always a concern, and it's always a natural phenomenon as a human being. If you have something that happens to your child and then Kawasaki disease happens after that, you want to make those two linked in some way. But there is absolutely no evidence that vaccines are in any way linked to Kawasaki disease. The other side of that is that Dr. Trabeculae and I are contacted frequently by parents who have a child who had Kawasaki disease and then develops something else, seizures or asthma or other diabetes, other medical conditions. Right now, at the present time, we have no evidence to suggest that there are any other diseases that are linked to Kawasaki disease or to which children who have had Kawasaki disease are more susceptible. Now, that might change in the future, but right now, that's where we are. And our children who recover from Kawasaki disease go on to regain their normal baseline and are not predisposed to anything that we know of. Having said that, if you are a young adult or you're over the age of 15, we'd love to have you join our adult KD study, because to have a really robust answer for that question, we would need to follow thousands and thousands of KD patients into adulthood where we can actually compare them to a control population and determine whether their chances of having some kind of problem are greater. So we really encourage you to sign up for our adult KD study so we can address that more definitively. There might be a few more here. So there's some questions about variability in the echoes, where the echo was normal and then the echo wasn't normal. And for all of you who have sat there looking at the echoes, they're not the kind of really precise imaging study that you saw from Professor McVeigh. The CT kind of imaging that he can do is extraordinarily more detailed than what we can do by echo. But ours is simple, easy, no radiation, and relatively inexpensive. So if there are questions about findings that were there and then not there, whatever, one path is to do the CT calcium score, a very cheap, low radiation test that Dr. Gordon spoke about, or if more detailed imaging is necessary, then CT angiogram, and even with the squeeze component as part of our research study would be another way to make sure that everything's working well. So I think that's it, and we'll be around for a little bit afterwards, but I want to thank everybody for participating. Is there anything else that we...
Yeah, you have to stay put for a moment. So I'm going to... we have a little surprise, but we were expecting... Thank you, Samantha, for running back there and telling them to hurry up. Perfect timing. So we have a little surprise because tomorrow happens to be the birthday of not only Dr. Jane Burns, but she shares September 30th as her birthday with Joan Pancari, who's our Kawasaki nurse that many of you know. So they reluctantly are coming up here. And of course, we all know Dr. Burns loves pink, so the Hello Kitty cake is for her. No, just kidding. That's for Joan, because Joan loves Hello Kitty. So on behalf of, I have the honor of standing up here and saying that on behalf of all of our patients, our parents, our staff, myself, our wonderful families around the globe, collaborators and everybody, we want to wish you a very happy, healthy, wonderful birthday. And with that, a little birthday singing will have to happen, right? So on the count of 3, 1, 2, 3. Happy birthday to you. Happy birthday to you. Happy birthday, dear Jane and Joan. Happy birthday to you.